Hey, welcome back to Not So Complicated, and today we'll try to uncomplicate acute kidney disease. Its types is in pre-renal, renal, and post-renal, right? So pathophysiology, clinical picture, diagnosis, and management. So let's begin without further delay. Acute kidney injury, it is actually like it was used to be called as acute renal failure, and it is a condition where there is sudden decrease in kidney function, and that is characterized by increase in serum creatinine or a decrease in urine output, that is oliguric condition, or both of them simultaneously, right? And this should happen within the 7 days, within 7 days of symptom development, right? So that is how acute kidney injury is defined as. So this is the overview of the types of AKI, that is pre-renal due to marked decrease in renal blood flow, and renal due to damage within the kidney structures, and post-renal due to obstruction of urine outflow. So let's talk about these types in details actually. So the first one is pre-renal type, right? So pre-renal type, that is due to hypoperfusion, and that can be due to hypovolemia, as in dehydration or hemorrhage or excessive blood loss, right? So that can also happen due to shock, as in septic shock or cardiogenic shock. So these are the reasons for pre-renal AKI. And for renal or intrinsic AKI, there are three different reasons. ATN, that is acute tubular necrosis, that can be due to ischemia, nephrotoxins, as in drugs like aminoglycosides use, and also glomerulonephritis, as in post-streptococcal glomerulonephritis, and in acute interstitial nephritis when drugs like NSAIDs are used. So these are the reasons for intrinsic or renal AKI, and there are reasons for post-renal AKI, as in kidney stones. Obviously, these cause obstruction in the lumen, causing the back pressure of the urine, right? So that will infiltrate or impact the glomerular filtration rate. So basically, kidney stones or benign prostatic hyperplasia or tumors can lead to post-renal AKI. So how these will lead to the pathophysiology of AKI or development of clinical picture, we'll be talking about that now. So acute kidney injury is a rapid decline in GFR actually. We all know that by now, right? So this will lead to azotemia, that is increase in blood urea nitrogen, and obviously fluid or electrolyte imbalances. And how that happens, let's talk about that in three different types. So in pre-renal type, that is hypoperfusion injury, as in shock, what happens is reduction of glomerular pressure happens, and that will trigger RAS system, and ischemic injury will occur. So that happens in pre-renal. And in intrinsic cases, ATN from ischemia or nephrotoxins, or GN or AIN, can lead to damaging of tubular epithelium, causing cast, right? So and these casts of like epithelial cells will block the lumen, and that blockage of lumen will lead to like blockage of the urine flow in the renal tubules, and that will lead to the oliguria, right? So in post-renal there is obstruction. So in renal there is intrinsic obstruction. In post-renal it can be due to intrinsic or extrinsic obstruction. As in intrinsic obstruction, that can be due to renal calculi or stones, and in extrinsic, that can be due to tumors or BPS, right? So this will increase back pressure, impairing filtration. I had talked about that earlier. So what will happen after this? So clinical features will develop. So these clinical features are actually divided in three different phases. The first one is oliguric phase. You have to remember this very well. So oliguria is less than 400 ml of urine per day, and that occurs within 1 to 7 days of acute kidney injury. So in urine analysis, you can see the casts, red blood cells, white blood cells, and specific gravity fixated at 1.010, right? So the metabolic dysfunctions are metabolic acidosis, hyperkalemia, hyponatremia, elevated BUN and creatinine, and also fatigue and malaise. So these are the effects in oliguric phase. And then diuretic phase happens, right? So diuretic phase, talking about that, there will be gradual increase in urine output. So that is this phases. So from first phase to the third phase, the symptoms actually get relieved, not get exaggerated, right? So that is how you remember. So there is gradual increase in urine output, that is 1 to 3 liter per day to 3 to 5 liter per day. So hypovolemia, dehydration, hypotension can happen, BUN and creatinine levels begin to normalize. So the last phase is recovery phase, and in this phase, GFR, that is glomerular filtration rate, will begin to increase, and blood urea nitrogen and creatinine levels plateau, and then they start to decrease, right? So these are the clinical features. So how do we treat these symptoms? Let's talk about that. So cause specific treatment is in pre-renal syndromes or pre-renal AKI, we give them fluids, as in IV saline, to like to compensate the fluid loss or hypovolemia or hypoperfusion injury, right? So you have to use crystalloids in there, and in intrinsic we have to obviously stop nephrotoxins and start steroids as in the case of glomerulonephritis, and in post-renal you can use catheter or stenting, right? So in supportive treatment to treat hyperkalemia you use insulin or kyaxalate, and for uremia you have to do the dialysis. And this right here is the diagnostic criteria of AKI for 3 different stages. So in criteria, patients must have one of the following, that is increase in serum creatinine ratio, serum creatinine greater than or equals to 0.3 mg per deciliter within 48 hours, or increase in serum creatinine greater than or equals to 1.5 times like baseline, that is known or presumed to have occurred within the past 7 days, and urine volume less than 0.5 ml per kg per hour for 6 hours. So that this one of them must be there to diagnose AKI. And for severity grading of this AKI, that is stage 1 AKI, 2 AKI and 3 AKI, the another diagnostic values are that 1.5 to 1.9 times baseline serum creatinine, or greater than or equals to 0.3 mg per deciliter increase in baseline serum creatinine is stage 1. And in stage 2, 2.0 to 2.9 times baseline serum creatinine, so that is stage 2. And in stage 3, 3.0 times baseline serum creatinine or increase in serum creatinine to greater than or equals to 4.0, or renal replacement therapy, example dialysis. So this is the diagnostic criteria for acute kidney injury, and that is all about acute kidney injury. Thank you for staying with me, and please subscribe for more clinical pulse like this. Thank you.